And what the CROWN trial showed is that for individuals who are on Lorlatinib, it's their first treatment they received, over half did not progress at 7 years. So that is remarkable. But it really is changing our perception of what these therapies can do and how much hope they can provide.
So I'll be brave if you're brave.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at Go-To for Lung Cancer. And for those of you who may not be familiar, the Living Room is intended to bring to you live and in real time conversations with key opinion leaders across varying aspects of lung cancer. And we couldn't be more thrilled tonight. Dr. Kyle Concannon here from Colorado University Anschutz, and I'm going to let him introduce himself in a little bit, but this is our ASCO, our best of ASCO. So for those of you who may be new to the programming, ASCO is the American Society of Clinical Oncology, and it's an annual meeting held in Chicago. It's not specific to just lung cancer, it's all cancers, but it's where people are reporting out, pharmaceutical companies and others are reporting out on the data from trials and studies. And we're gonna have a conversation tonight about what's coming down the pike. What is the next best thing, the up and coming? Welcome to everyone in the room, those of you who are joining us online. This is one of our most anticipated meetings every year because anyone living with lung cancer wants to know what their plan B, C, or D might be. And that's what we're here to talk about tonight. So with that, I really hope that, as always, that tonight's discussion is valuable to you. We want it to be valuable to you. We want it to bring to you the information that you need. So I'm going to reiterate again, questions throughout. There are no stupid questions. Sometimes, and I've heard this in the past, where people will say, well, I don't want to come in and interrupt the meeting or make it just about me. But again, this is for you. So there are no stupid questions, so please feel free. So like I said, we have Dr. Kyle Concannon. He's an assistant professor of thoracic oncology, Division of Medical Oncology, University of Colorado Cancer Center. And before we jump into the conversation, Kyle, if you wouldn't mind telling us a little bit about yourself and why lung cancer is an area of focus for you.
Sure. So thank you all for having me. It's a lovely outing here. Really thrilled to go into some of the details for ASCO. Always just such a great avenue to go to. We learned a ton. A little bit about me. I'm originally from rural Vermont. I grew up in a rural, well, I guess all of Vermont is rural Vermont, but I grew up in a town where 7,000 people. My entry into medicine was I had a brother who had a really rare genetic disorder, and my family didn't have a whole lot of healthcare knowledge. None of my family had been to college. So we didn't really understand the nature of that genetic disease or how genes work, how mutations can lead to an illness. And when he was going through his challenging times, we felt really in the dark. We felt really lost. We didn't have any knowledge of why the disease was unfolding how it was. And then some serious life events happened. He got really sick, pulled through. We were in the Make-A-Wish Foundation, all those things. But then just the feeling of insecurity and fear we felt drove me to want to understand molecular biology and be able to really use an understanding of what's going on, not only to iterate on advancements that have happened and help make better treatments for genetic-based diseases and things like that, but I also really acknowledge the need to understand what's going on. So I went through undergrad at the University of Vermont, med school at the University of Vermont. I did my internal medicine training at the University of Washington up in Seattle, and then physician scientist training at MD Anderson Cancer Center. And from there, I now have my own laboratory at the University of Colorado where we study how these diseases, how lung cancers evolve over treatment and how we can target them mostly with CAR T-cell therapy is what I'm developing now. And then I run the Cracking Cancer podcast, also aimed at following in your footsteps of trying to educate individuals to better understand what's going on.
Yeah, I love that. I love that. Thank you so much for flying out here and being with us today. The information that you provide to our community is so incredibly valuable. And one of the things I love most about this meeting is bringing in like-minded people who understand that the patient's understanding of what's happening, what's going on, what's next, is an incredibly important part of this process.
Yeah, I think we talk so much about mortality, but a big part about morbidity, I think, the experience of living with a disease is that understanding and being able to cope and just not feeling helpless to something.
I love it. Well, let's jump in, shall we? We've got a lot to cover. We're not going to cover absolutely everything. We're going to cover a lot of the highlights. So one of the biggest things, the biggest themes, I guess, if you will, to come out of ASCO this year was precision medicine and targeted therapy. So can you explain a little bit about what we mean by precision medicine?
Yeah, when I think of precision medicine, and I would say that that's a topic that is probably evolving over time in a good way, but usually it's understanding some key element of an individual's cancer that lets us uniquely adapt a treatment to that specific cancer. I think in the beginning that meant mutations. And by and large, I think that still means mutations for many individuals' cancers. But now it's growing to even mean things that we can identify on the cell surface and characteristics and attributes of a cancer. But I think at its core, it's studying the cancer specifically and understanding that biology to weaponize the biology. How can we specifically select treatments in a precise way against that cancer?
Yeah, I love that. And especially when we're thinking about lung cancer, it's an incredibly complex disease. When lung cancer first entered my life, when my mom was diagnosed in 2003, it was chemoradiation surgery if you were lucky enough to find it early. So it kind of felt a little bit like throwing pasta at the wall, right? And everybody kind of got the same thing, and let's see, how it works. But now the treatments are so unique to the individual, and I want to touch on biomarker testing because I know where you are and where you're seeing patients that's happening, right? I mean, biomarker testing is something that is norm, and not just biomarker testing, but comprehensive testing to really dig deep into what is driving or potentially driving this cancer, but it's not happening everywhere. So can you talk about the importance of biomarker testing, why it's such an important part of the diagnosis process?
Yeah, I don't know if I can talk about it enough. It's critical for the treatments that we give pretty much in every stage now. And this is a key element when we see a patient who's newly diagnosed. A lot of times there is pressure to start something immediately, and sometimes we have to do that. We can't wait for biomarker testing, but most of the time, it's one senior physician to me had phrased it that it's an emotional emergency, but it's not always a medical emergency. And if it's not a medical emergency, we get the biomarker testing, which means we're looking at what are the specific mutations that this tumor has that make it particularly susceptible to a treatment. And that, even right from the get-go, right from the first treatment they're going to receive, is going to align what we do with what they're going to get and offer them the best chance that they have at the best outcome. And I'll say we see this in different centers, and sometimes there's true delays. Not every system has the benefits that some of the academic systems have with quick turnover. But when it's available, we want to get that comprehensive testing to give you the best treatment first, and that really does matter.
I love how you described an emotional versus a medical emergency, because asking someone who's just been told that they have stage 4 lung cancer, for example, to wait the 3 weeks, for tissue testing to come back is painful to the person who's just been diagnosed and to their family members, right? But it is so important to ensure that the patient's getting the right treatment at the right time.
Yeah, and to build on that, I have an example in my clinic even just last week where this happened. There was a sense of strong urgency to start a treatment. And, who knows in retrospect if it was the right call or not, but it did prevent us from being able to do biomarker-directed clinical trials because they're already on something. So foregoing that in the beginning in the interest of being quick can limit options. So it is important to prioritize the biomarker testing if we can. And now we have not only the tissue-based sequencing, and we can look at it at the tissue, but we have the blood too. There's some limitations with the blood, so it's not perfect. But often if you see something in there that's actionable, it's usually true. If you don't see something in there, that may not mean nothing's there. It's like fishing. If you don't catch a fish, it doesn't mean there are no fish.
Yeah. I love that, and I think I just want to reiterate what you said about all stages of a lung cancer, because that wasn't necessarily the case, 5 years ago, where that was standard of care, but it's so incredibly important now, and I know we're going to touch a little bit on some early stage stage disease. I'm going to ask one more biomarker testing question of you, and then we'll jump into some of the data. How important is it at progression? So if someone's progressed on their therapy, that they repeat the test?
Yeah, I think a while ago there was a perception that the initial biomarker testing was the biomarker. If you had an EGFR mutation, if you had an ALK, then that was the pathway you went down. And what we're learning as our therapies are getting better is tumors are having to evolve in unique ways where they're getting additional mutations. Some may be in the gene that was originally mutated. You can get these secondary mutations in that same thing. But we're seeing other things popping up that I don't know if we saw 10 years ago to the same degree. And those are often targetable. And if you can use a pill and spare someone from long duration of chemotherapy, we're seeing that more and more now. So it's critical that at every progression, if you have the ability to do it, I always recommend biomarker testing.
And I know I'm squirreling a little bit away from what you and I had talked about, and I said that was the last question before we jump in, but it's not. When thinking about biomarker testing in clinical trials, where are we with that, and why is biomarker testing important when we're thinking about clinical trials as a potential best first, second, third step?
Well, a lot of times the type of clinical trial that someone is a candidate for is wholly dependent on what that biomarker is. In both ways, it may mean that if that marker is present, then one can enroll in a trial that's specifically geared toward it. But the flip side may also be true, where I'll give you an example. If someone has, say, an ALK mutation and they're looking for a trial of an ALK inhibitor, well, if they also have an EGFR mutation, a BRAF mutation, that trial is not a good fit for that individual. I would not expect that to work very well. So it's critical for identifying the right trial that would be helpful and the wrong trial that doesn't pair well in a precision oncology format for that specific tumor.
Okay, I'm done with questions that aren't on my paper. So let's jump in, and we were just talking a little bit about ALK. So let's start with ALK, and one of the longest running studies to be presented this year, and that was the CROWN trial.
Yeah.
Can you talk a little bit about what we saw there?
Yeah, so the CROWN trial was a first-line trial where they looked at Lorlatinib, the oral pill that targets ALK. It's a third-generation tyrosine kinase inhibitor, and this is how we iterate. We take a molecule, we make it better, we learn more about how it's binding to its pocket, and we figure out what caused resistance, how can we overcome that. Do that a few times, you get Lorlatinib. And what the CROWN trial showed is that for individuals who are on Lorlatinib, it's their first treatment they received, over half did not progress at 7 years. So that is remarkable. And I think it really challenges some of the paradigms we had, which one is that we had this feeling that tyrosine kinase inhibitors in of themselves they're good, they're better than chemotherapy, but are they alone sufficient? And we know that there's still the other half of individuals or so that did progress, but the fact that the first treatment someone got could last this long is remarkable, and now we're faced with questions. Do you take them off the medicine? How long do they need to be on it? Our practice is to maintain them on it, but it really is changing our perception of what these therapies can do and how much hope they can provide. Sure.
Is that for all stages?
So these were in individuals who were diagnosed at stage 4. So their first treatment for non-resectable, metastatic, incurable disease was Lorlatinib, and then come 7 years later, they're still on it. And our clinical experience shows that too. I have many patients who I'm caring for who have been on these inhibitors for 10 years. It's a really, really nice piece of data in our armamentarium when someone's coming in and they have a new diagnosis of ALK, stage 4 incurable lung cancer, and I get to tell them that this perception you had of I have metastatic lung cancer, thinking months, and I show them the curves of this and say, look, it's been 7 years and these people are doing great. Is it a guarantee it's everyone? No. But it's, in that trial, most people, and it's tremendous hope, and it's real hope. It's real hope that isn't fabricated and we're not polishing. It's that's the data.
And this is the most recent data, is the 7 years PFS or progression-free survival. We're still watching it, right?
Yeah.
Yeah.
Yeah. So we'll see what 9 years ends up showing, and we wonder as that tail goes out, are those patients cured? Do we know? We don't know. We do know that when you treat individuals with an ALK inhibitor, the ALK-driven disease does melt away in quite a bit of patients. Is there those drug-tolerant persister cells left around? The science we thought before suggested, you need to be on it. There's a small population of cells that are surviving it but not thriving. They're not growing. And the thinking is if you took the medicine off, they would grow. But data this long out, I think, does begin to challenge that.
I'm willing to bet there's a lot of people who might say, I'll go ahead and stay on drugs just to be sure.
It is definitely my practice to keep people on the medicine. Particularly, we can identify doses of Lorlatinib that are pretty tolerable. So with that data, why mess with such a good thing?
Okay, next up, EGFR, specifically Exon 20.
Yeah. So Exon 20 is an interesting element in of itself. Years ago, I was one of my first research ventures was at Mass General Hospital. I worked in the Haber lab, my first lab gig, and I'm eternally grateful to Dr. Dan Haber and Shamala Maheswaran, who gave this kid with no research experience a job in their lab. And I worked on EGFR, and I worked on EGFR mutations, studying Lorlatinib, the first drug that came out. And my thinking at the time was an EGFR mutation is an EGFR mutation is an EGFR mutation. And then what we've learned as time has gone on is that that is not sufficient. Not every EGFR mutation has the same level of, I'd say, oncogenic drive. They're not all the same level of aggressiveness. They don't all respond the same to the treatments we have. Mutations can mean that one of the many building blocks of that protein are mutated, and you can just have one of those switched. Bits can be cut out, bits can be inserted. EGFR exon 20 was the topic of this year's ASCO. I'd say that was probably the big highlight. And this particular mutation happened to be in an area that's really hard for other medicines to actually treat. So despite us having EGFR inhibitors for this long, we didn't have anything that really worked for EGFR exon 20. And those those improved outcomes that everyone else with EGFR mutation or many other people were experiencing were not related to them. So this medicine, sunvozertinib, was highlighted here, and this was for individuals, again, with stage 4 disease, and they were treated with either sunvozertinib or the current standard of care, which was chemotherapy. That's what really the standard of care for exon 20 mutations was. And they identified that for individuals who got the sunvozertinib, they had a 10-month progression-free survival compared to about 7 in chemo, so 7.5. So it had about a 3-month improvement in progression-free survival. And I think that in itself is a huge win. That's a great takeaway, that we can have an oral option that's fairly well tolerated compared to chemotherapy, and it did better than the chemotherapy did. And then the overall survival is still maturing. And I'll say for individuals who are looking at the trial for the exon 20 sunvozertinib, one really critical thing to keep in mind that I really love that they did is they allowed individuals who were on chemo when they progressed to take sunvozertinib. And about 90% of them did that. So that's really critical when we're looking at the overall survival difference. You may not see much of a difference there because the individuals who were on the chemo arm then got sunvozertinib. That will also give us some more information. Is sunvozertinib better when we've reduced disease down with chemotherapy? So if that arm ends up doing better in the overall survival, I would buy that.
Yeah. So, and I'm going to ask this question, and we may not have the data yet, but are the people who were in the chemo arm who were switched to the sunvozertinib, Zigfrovi, was the PFS still, were we still seeing the same response?
We'll have to see. So that's the PFS2. I don't know if that was reported there.
Okay.
But that's a great question.
Yeah.
What I think when I was looking at the overall survival trends, the overall survival between the two arms wasn't dramatically different.
Yeah.
But I think that explains why, is that if you had chemotherapy, you could then get sunvozertinib.
Yeah.
And on one hand, we tend to look at this data and we say, oh, it did better than chemo, and that's great. But I think beyond that is the fact that now we have another treatment option. So it's not just that it's better than chemo, you still get chemo, you still get to keep that. Now you also get sunvozertinib, and we can look at new ways to integrate these together, like we did with other EGFR mutations, where you might give chemotherapy and, the TKI, the pill of osimertinib. Maybe that happens here.
Yeah. The succession of the treatments and where you sort of place them is important when you're looking at longevity on drugs, right? If chemo's X and a targeted therapy is Y, and Rick, I know you know all about this, and that's why I'm looking at you. But what's my back pocket if and when this stops?
And a lot of times we're adopting this treatment paradigm where it's not always either or. Yeah. Sometimes we'll give some chemotherapy at a time, maintain them on, in this case, sunvozertinib or whichever tyrosine kinase inhibitor pill they may be on, and we can get a lot more mileage out of that.
Yeah. I'm looking around for any questions. Michelle, are we good before I move on to RET? Yes. Oh, I see one. Yeah.
Okay, so for the Crown trial, I understand that it was it's remarkable, right? The outcome. But what about for patients who are short responders on lorlatinib? Where's the hope for them? How are they not frustrated by the hope, but then it's not working for them? They're sort of stuck. So what's your perspective on that?
Yeah, I think you raise a critical point about how do I identify what we collectively call high-risk populations. And some of it is in the DNA. We know that certain subgroups of ALK, the variant 3, so depending on the exact ALK mutation, that may be a higher risk group. If there are other mutations with it, like a P53 mutation, that's another high risk group. And I think there's a consensus that we need to do something. We need to start looking at how do we escalate treatment for those individuals in a way that makes sense to hope to get them the same outcomes that you're seeing in the overall population, the people that are doing really well. And then the other question is, well, now we have additional tools we didn't have before with circulating DNA. So you can find out earlier, I believe, individuals who are starting to progress, perhaps even before it shows up on a scan. And should we be acting then? This concept of treat on molecular recurrence. So we can follow with the scan, and then do you, one, wait until you can see a lesion and then maybe radiate it or you cut it out if it's just one? Or do you say, hey, as soon as that comes up, should we be doing something additional? That's an unanswered question in my opinion. But I think those are the tools we need to really start leaning into to make this hope a little more universal.
Yeah, and we're gonna, a little bit later in the conversation, we're gonna take a deeper dive into what ctDNA and MRD are. It's fine. You looked at me like, oh, I talked too soon, but it's not. Because I think it's really relevant, and I think you're right. I mean, I think there's not just one tool in the toolbox, right? And so it's determining which tools need to be used and when they need to be used.
Well, in the training that I had, I was taught that 1 centimeter of tumor that's on a scan is about 1 billion tumor cells with a B. So if you have that many tumor cells that all have the capability of progressing, shedding, progressing, causing resistance, that's a tremendous amount of resistance potential. And in my mind, that's the equivalent of if someone has high blood sugar, you're waiting until it gets to 700. No, maybe we need insulin a little earlier. Maybe we need to do something when it's below the limit of what we can see in a CAT scan, or we can use some of these other tests.
Okay, let's talk a little bit about RET, and especially as it relates to how we're seeing targeted therapies move into earlier stage disease.
Yeah, RET is a mutation that's close to the heart. My aunt-in-law had RET-driven lung cancer, actually, and benefited from this medicine. So this is the LIBRETTO trial, and we're trying to figure out how can we identify really the best ways to use the tools we have. So this wasn't a new medicine that came out. This medicine, selpercatinib, was around before. But we were asking the question, for individuals who have resectable disease, so cancer that didn't spread into the lining of the heart, the pleura, there wasn't a malignant effusion around the heart, or around the lung rather, it didn't spread elsewhere. We thought we could really get this all out. The standard of care, because immunotherapy doesn't work very well, was largely observation. So what they did is say, well, we've seen some good examples of giving a pill before. It works really well for EGFR-driven lung cancer, for example. Maybe it'll work really well here. So what they did was they gave individuals this selpercatinib for 3 years, and then for the individuals who received that, only 4% had progressed versus 30%. And I think the critical element here is that by tailoring the specific medicine to the exact mutation you have, that this is the way we're going to get the most benefit for these individuals who have curative potential. And that delta of 30% progressing versus 4 is pretty alarming. You know, it's alarming that we are not universally doing these kinds of treatments. And I think it's also a bit alarming that in all these patients, we thought they had curably resectable disease. But in a lot, we find there's stuff left behind that benefit from the addition of a pill. And while we've had some of these trials in RET-driven lung cancer, ALK, EGFR, there are still many biomarker-directed treatments that aren't always given at this time.
So that's what I was going to ask you. So when what we're talking about, particularly in early stage and the emergence of data showing that there is benefit, EGFR, ALK, you talked about those, either in the neoadjuvant pre-surgical setting or the adjuvant setting, which is post-surgical. My question about this is exactly based on what you were just saying. Is your sort of hypothesis, or what are your thoughts around biomarkers? I mean, we've seen the data in a few of these. We're now seeing it in RET, but across the board when we're looking at targeted therapies.
I'll preface by saying this is a bit of a data-free zone in terms of, is the same thing applicable everywhere? Yeah. But I tend to be a fairly aggressive oncologist. I'm an early adopter of things, and I'm okay reading the tea leaves a little bit. All that to say, I think the data is clear that you need something else in these individuals who have resectable disease that isn't a tiny, small lesion. Usually we have a 3-centimeter cutoff. So for individuals who have lymph nodes that are positive or large primaries, I think you're going to need something else. Yeah. And for many of these other tumors that have mutations with targetable things, you know, ROS1 might be an example, I think adding on something after that is what we need to do. The challenge with some of these, though, is to wait for a trial may be a while. Some of these mutations are quite rare. Talk about an NRG1 fusion or something like that, where you're getting 0.1% of individuals with lung cancer have one of these. To get a trial that has the numbers that you're going to want to convince yourself may be a long time. So I think a lot of times we all acknowledge that it's the right thing to do. Getting insurance to pay for it may be a challenge, and when do you stop? That's another challenge.
What point? Yeah.
Yeah, they choose, depending on the trial, you know, they're choosing a couple years. Is that sufficient? And we need more long-term follow-up to better answer that.
Well, one area we do have data sticking in the early stage place in the neoadjuvant setting, so before surgery, is in ALK. Let's talk a little bit about what's going on there. Yeah,
and I struggle with my colleagues too. Is it better to give something after surgery? Is it better to give something before? I believe it's better to give something before. I'm basing that on feelings and emotion. The Lorien trial that we're talking about here, they gave that medicine Lorlatinib that did so great in the Crown trial for individuals who had resectable or borderline resectable disease. They gave Lorlatinib up front, and then they gave it for 3 cycles, 63 days. And then they did another evaluation. And the way the numbers played out was something around half of the patients in the beginning they thought were resectable. About half they thought weren't. Of the half they thought were not resectable, half of them became resectable. So that's a pretty critical element. I'm going to speak a little more. This is a topic I can wax poetic about. Yeah. So the individuals that weren't resectable, about half of them became resectable. And then, so that means about 75% of patients got surgery, when only about half would have by our current standards. And the interesting thing is pretty much all of these patients had what we call R0 resections, meaning when they looked at the margins were all clean. I think there was one patient that didn't. They had a 97% R0 rate. So what that means is that for the individuals they thought weren't resectable, For those that went to surgery, the surgical margins were clear. That was okay. They did a good job. And I thought what was more crazy about that was that when you looked under the microscope, about half of the tumors they took out were totally dead, were pathologic complete responses. And I still struggle to reconcile that. I don't know what the implications of that end up meaning are those the same patients that in Crown have been doing so well? Are those tumors truly gone?
Yeah.
So to me, that gives me tremendous hope that maybe we're doing a little bit better than we think we are in ALK for the patients who have those excellent responses. And then what's different about that? How do we identify the critical elements of those tumors versus those who progress? Can we manipulate that in some way to give more people this extra benefit? Those numbers, even though it was a small trial, 43 people, what that paradigm changes in my mind is let's reconsider what we think is resectable. And we do this at many institutions I've trained at. Just because someone's not resectable in the beginning does not mean they're never resectable. So for many patients that I treat, our paradigm following this, whether it's stage 4 or stage 3, 2, we can start with an upfront treatment and let's see how it goes. Yeah. Let's reevaluate, and if we get a great response in these other areas, let's say someone with metastatic stage 4 ALK-driven lung cancer, well, if they actually had complete response in those other areas and you just have the one area left, maybe you are curing people or getting something very close to that.
Yeah. I can see where your sort of emotional response to the neoadjuvant concept is, and I love the way that you explained all of that. And I've had conversations in this very room with other medical oncologists and thoracic surgeons who are thinking the same thing you are. Like if we're looking at everything and all we really think is still metabolically sort of relevant is the primary tumor, if we take it out, what does that look like? Are there trials, I know we're not talking about this, but are there trials looking at that, or are these just sort of N-of-1 things happening around the country?
There's a lot of N-of-1s, and it's too bad we don't have a pooled resource for those N-of-1s, but I think many institutions are doing it, and we could very reasonably pool our data soon.
Yeah.
But there are trials. There's, at my alma mater of MD Anderson, they're running those in EGFR-driven lung cancer. They had the North Star trial, and they have the Bright Star trial in ALK-driven lung cancer. And the data, by and large, shows, and some of the other data they've collected, this concept of consolidation. So if you give a systemic treatment that goes everywhere, shrink stuff down, let's look at what's left. And if you can reduce what's left in a way that is not terribly toxic, radiation, maybe surgeries that aren't too morbid, then by and large, the more you're able to do that safely, the better people tend to do. And again, it gets back to that thinking that if 1 centimeter of tumor is 1 billion tumor cells and you're able to remove those, that's a tremendous number of tumor cells that you're removing from the resistance pot.
Yeah.
That's kind of how I think about it.
Yeah, fascinating. Okay, we're going to transition here because targeted therapies aren't the only areas where we're making progress, right?
Yeah.
Immunotherapy, we talk a lot about immunotherapy in here. What's going on there? What kind of improvements are happening with immunotherapy? Sure.
So, immunotherapy is interesting because in the beginning it started out by, we can target the PD-L1, PD-1 axis. This is the don't eat me signals that the tumor cells put out. We block those, the immune system can come in, identify them as foreign now, and then clear them. That's the premise behind it. And just like in the tyrosine kinase inhibitor space, the Lorlatinib to osimertinib or crizotinib, alectinib, brigatinib, Lorlatinib, as we go through and get progressive iterations, we can find little tweaks that we can do to improve on the success we had. And I think the immunotherapy space is in that area too. So the realm we're in now is how can we iterate on the success of checkpoint inhibitors, the things that target the PD-1, PD-L1 axis. What can we add to that? Ivonescimab was the big example here, and what that does is it has a part of it that binds to PD-1. It's that same checkpoint blockade that we've been using for the last several years now. And then it also adds on a bit that targets the vascular endothelial growth factor, or VEGF. VEGF was a really hot topic when I was in undergrad because this is felt to promote new blood vessel formation, which is felt to be critical for tumor growth. So we thought inhibiting that was going to be a real game changer. It didn't turn out that way, unfortunately. A lot of experiments in there didn't pan out. But paired in the right circumstance, it seems to be really effective. And part of that is through that mechanism. Part of it is also probably reprogramming the immune system in the tumor itself. I think it seems to have an effect on the immune component within the tumors. So this ivonescimab treatment binds to both of those. And what they did, and here in squamous cell cancer, is they looked at, well, is the ivonescimab molecule that binds to both PD-1 and VEGF plus chemo better than just a regular immunotherapy plus chemo? And the median progression-free survival increase was about 4 months, from about 7 months to 11 months by that addition of the extra component in ivonescimab. I mean, that's about a 50% increase in progression-free survival. And the overall data on these iterations is not fully mature yet. These are still fairly new. But at least in the data that they reported at 2 years, the overall survival was 65% versus 50%. So we got a pretty large incremental gain from that addition in the ivonescimab.
So we see these best responses, I think I heard you say, in the PD-L1 positive.
So it's interesting. The checkpoint inhibitors traditionally do really well as we go higher in PD-L1. We think of that as that was an immune escape that they used.
Yeah.
So if you block it, then they're susceptible to it. And I think there still is an incremental benefit with more PD-L1. But the interesting thing is once you add on the VEGF component, it's still beneficial in people who have a lower PD-L1. So it's not that no PD-L1 or PD-L1 negative still benefit. The hazard ratio is I made a note of that, it was 0.64. So that's, they're deriving a 36% decreased risk in progression, even if they don't have PD-L1 elements. So this anti-VEGF component, who knows what it's fully doing in that immune microenvironment, but these are the iterations we need to keep improving on. I think these medicines that we've seen have curative potential. A lot of times they don't work until they do. PD-L1, that element worked pretty well right out the get-go. But then we've tried many iterations and then you hit something. And then we need to keep trying more iterations and we hit something else. So these are the medicines that I see with curative potential, and I'm eager to see more research in that field.
I am too, and I think, when immunotherapy hit the market and got approved and all the direct-to-consumer ads were all over television, like everybody wanted to be on immunotherapy, right?
Yeah.
And so although, I believe awareness is key, and so I'm not mad about the DTC because it got people talking. Mm-hmm. I think it did create a lot of confusion, at least in the patient population, where everybody was like, no, immunotherapy is where I need to be.
Yeah.
And PD-1 and PD-L1, it was dependent on that back then, right?
Yeah.
As well as tumor mutation burden and all these things we were looking at that now are still relevant, but not as specifically relevant as they were, I guess, when IO first came out.
Yeah, I think that's true. And the other interesting element is we understand that individuals with certain mutations aren't going to respond very well. How that's the case, we're still learning, really. But the iterations we need to make everyone have the same responses, they're happening. But it also is interesting because to your point, well, once you've iterated enough and everyone's responding really well, do you need the biomarker anymore? And I hope we get to a place where these biomarkers that are so critically relevant become less relevant because our therapies become so good.
Yeah. And I think all of this to say, we said at the beginning of this meeting, or I said, and I know those of you who are a regular, either in person or viewer of this program, hear me say it all the time. If you think you knew something last week or last month about the best way to treat a specific lung cancer, you're probably wrong, because things are happening so fast and so furious, and it's so complex, which is what I was talking about, mentioning earlier. So I'm going to butcher the name of this drug because it's new enough that I haven't allowed it to roll off my tongue. But it's Pumitamig.
Pumitamig. Yeah.
Yeah. Say it again.
Pumitamig, I believe.
Pumitamig. Yeah. There it is. Okay.
Another checkpoint inhibitor that has a combined VEGF component. So this is from a different company. This is BioNTech, I believe. So it's really, this is data that's come together, and they looked at both non-squamous and squamous, so adenocarcinoma, the more common variant, and squamous cell carcinoma, and they showed that it really worked well in both, was really the takeaway. Comparing both this data is a little earlier, but the objective response rate, meaning patients got a good response from it, was 82%, regardless if you had squamous cell or adeno. So I think the key takeaway there is that it's not just one company's asset that had this benefit. That's not just one fluke of one trial. It does seem to be that many companies are going to be coming out with these types of iterations, and they're showing good benefit in individuals with.
And maybe you said it, and I just missed it because I was looking down at my notes, but I know you just mentioned it here with both squamous and adenocarcinoma. Is that the same for the others?
The one we were looking at before, the one we were talking about before, was squamous.
Okay.
But we've looked at these across all histologies, across different trials. Yeah, so there are a few different iterations from different companies. And many of these specific compounds that have these bispecific elements, the PD-1, PD-L1, and the VEGF, are actively in trials right now. I know we have a trial of it at Colorado, and many other institutions do too. So we have a frontline trial we're enrolling people in right now. And that's an interesting trial because that may be the only thing they get, a high PD-L1, and let's just see, can you get this one infusion, no chemo? So I think these are doing a really good job of pushing the envelope to say for the individuals who have those high PD-L1, good biomarker prediction, can we spare the toxicity of chemo? And that's another way to push the field. We have this perception a lot that more is always better, and when we're in that emotionally urgent state, people tend to want all the things at the highest doses. I think these trials are really critical to say what is truly sufficient and best balances the toxicity.
All right, let's shift to small cell lung cancer, which was, in my very humble opinion, not as heavily studied. I was going to say ignored, but I'll just say not as heavily studied for many decades. Yeah. And there's been a ton of really exciting advancements over the last several years, or a few years, however, define several or few. Let's talk a little bit about what's going on in small cell.
Yeah, I think you're entirely right. For years, it was what dose of what chemo, and if you got better tolerability than the other thing with no added benefit, then you got approved. It was a really hard field to study. It was a very hard field to make progress in. One of the biggest landmarks that came out initially was the addition of immunotherapy, which only improved progression-free survival by about 2 months, and we think that's in a subset of people. And then building on this idea that we can program the immune system or leverage the immune system was bispecific T-cell engagers. And what these do are they bind to the tumor cell and they bind to an immune cell and they co-localize them. They bring them together. And then the immune cell, turns out, kills the cancer quite well. So the Delphi trials, this is tarlatamab, is the name of the drug that I'm referring to, improved progression-free survival in patients who have already received chemo from 8 months to 14 months. So we got almost a doubling in progression-free survival in a disease that we didn't have anything for almost 30 years, essentially. And then what came out here was, well, how well does this work in the brain? And that's a really critical question in small cell because over half of patients with small cell lung cancer will at some point have brain disease. So it's really critical to get tumor control in the brain. And what they found was essentially that for an individual who didn't have brain mets, when they started on the trial, their likelihood of developing brain mets was about half of if they were on chemotherapy. We're still learning the best ways to use these tools and the best places to use them, but it was very, very clear that this was good for CNS protection. For individuals who don't have brain mets, this dramatically lowered the risk that you're going to get them. For individuals who do have brain mets, not only did they have excellent responses in the brain as well, but they also had about half the risk of those brain mets growing or developing new ones. And then the rate of a complete response where we're not seeing anything on scans, which is tough to do in small cell once it's already been treated, went from about 5 to 15% with these data. But I'd say the biggest element of this was that this has good CNS protection, and for individuals with active brain mets, this is a good treatment. And that was a really big unmet need, continues to be.
Yeah, huge unmet need. And CNS is central nervous system, right? So your brain, your spine, all that good stuff. All right, let's jump to, I think you touched on it a little bit earlier, but the CAR T-cell therapy.
Yeah.
Because this is novel, so if you could explain a little bit about what it is. I mean, as compared to what we've been talking about in this room for the last 15, 16 years, yeah.
Yeah, so CAR T-cell therapy, it's of interest to me. It's what my lab works on.
Yeah.
So these are chimeric antigen receptor edited T-cells, which is exactly what it sounds like. So what these are we take an individual's immune cells out of their body, we reprogram them to attack the cancer, and then they essentially have an antibody on them now, where if it binds to the thing you tell it to bind, the T-cell will activate and it will kill that thing. So we can reprogram them to attack largely whatever we want. What this trial did is they took a CAR T-cell that targets the DLL3 protein, which we've seen that's the target of Lorlatinib. It's a good target in small cell, and they made a CAR T-cell that binds to that. We actually had a trial before that did that, and it got some responses. There were only 5 or 6 patients in it, but then the responses weren't very well lived. What this trial did was they iterated on that, and they did some more engineering of the T-cell to say, well, can we add something in here that made it a little more resistant to being exhausted, which is a problem with these therapies. So this trial essentially was one of the first trials with a CAR T-cell in small cell lung cancer that showed benefit. So it's an early trial. I'm not going to get too much into the weeds for it, but the premise is that these CAR T-cell therapies have had curative potential in lymphoma. This is one of those things that I say it works, or it doesn't work rather until it does. And we've had groups now that are doing that iterative research to try to figure out how do we need to tweak this to hopefully get the same outcomes that we see with lymphoma where people are functionally cured.
So this is dependent on DLL3, and when we're talking about small cell, we're not typically talking about any sort of biomarker testing. How does someone who maybe is diagnosed with small cell lung cancer know whether or not they have DLL3 if biomarker testing is not standard of care in that population?
Yeah, it's a great question, and now I think the practice is if there's a trial, we can look for it. If we have a hypothesis, it is a test you can send to the right labs. And if one is interested in a trial, they would reach out to that center, and that center may run their tissue and look to see would you be a candidate. But actually, for a lot of the advancements that have been in small cell, there are ways that we're going to target the cell surface, and by and large, we're still not looking for that, because for many of those treatments, the degree of positivity didn't change much. We'll go into that a little bit when we talk about antibody-drug conjugates. But I think for this kind of trial, it does matter. So I think the research needs to come out. We need to show that there's a greater benefit in individuals who have either more or just some. Maybe some is enough. And then those who don't have any, you don't put on that trial. That's not a good treatment for them. Once we've developed that standard, then I think it's going to become more common practice. The challenge with these types of therapies is they're still pretty early.
Yeah.
So I'm an aggressive person, a heavy hitter. I want things that have curative potential, and I think we need more of this, but it's still pretty early. They're expensive trials. You're not going to see a lot of these trials. But as momentum builds and we get better responses, I think we're going to see it more and more.
All right. Thank you for that. TRIPLEX study.
Right. So this was an interesting study, and this speaks to the question we had, or the sentiment we were expressing earlier. This is individuals who have extensive stage small cell lung cancer, and then the standard of care is chemotherapy plus immunotherapy. The question they asked is, what if we also added radiation to the primary area? So they gave chemotherapy and the immunotherapy, and they also radiated the primary lung cancer. The thinking was twofold. One, if you kill the cancer there, are you helping their progression-free or overall survival? And two was, if we irradiate that tumor, is that priming the immune system? Is it releasing things in there that you can develop an immune reaction against and kill cancer? And the answer was pretty clearly no. The progression-free survival with that trial was much worse, actually. Or it wasn't statistically worse, but it was numerically worse in the individuals who got the radiation. And not only that, but the toxicities were high. 50% had esophagitis or inflammation of the esophagus, because that's the area that's getting radiated. And then to combine that with it didn't have any clinical benefit, it was a very clear answer that this is not the right modality.
Yeah, and I think it's important to touch on that because sometimes trials teach us what not to do, right? Yeah. What might not be best for the people that come after the trial, and I think it's important to talk about that because it's one of the the realities of trial participation.
Yeah,
you don't know till you know. Sorry.
And it pushes against the idea that we want to do everything we can immediately, and sometimes we need the data to say, actually, it's pretty clearly more harmful if we radiate while we're doing chemo and immunotherapy. So we have clear evidence to say, not a great idea.
One of the hottest areas of research, antibody-drug conjugates.
Yeah.
I'm going to ask you to explain again what they are first, and then talk into what we know now.
Yeah, that area has really exploded over the last couple of years. It's such a great element that we have these now. So what these are is we take antibodies, highly selective bits of protein, the components that your body will make when you're vaccinated and things like that can target really specific things. And then we make sure that they're targeting bits that are expressed on the tumor cell. On those antibodies, we fuse highly toxic chemotherapy. The theory is that that antibody will come, it'll bind to the tumor cell, and then kind of like a Trojan horse, it'll be internalized. The chemo will be cleaved, and then it will be delivered just to the tumor cell. A couple years later, there's probably a little more to it than that. Some of the chemotherapy clearly gets out in the rest of the body. People do have side effects to these. So they're not perfect precision medicine tools, but at least in a disease like small cell, they've been, I would go so far as to say, wildly effective. So for individuals who have extensive stage small cell, they can have received chemotherapy, and then tarlatamab, multiple lines of treatment. By and large, if they receive an antibody-drug conjugate, usually conjugated to a medicine that targets topoisomerase 1 or topo1 is usually the target of that chemo. If that combination comes in one way or another, most of these patients are going to get a response. And it's rare in small cell where we have these waterfall plots where you measure what's the change in the size of a tumor when you give them a treatment. And for many of these trials, they're all going down. So most patients are either getting control of their disease, and many, many patients are getting really good responses. And there's the two elements of the antibody-drug conjugate. We have the drug element on it, which again is usually targeting topoisomerase 1 these days. And then you have the antibody part. And we've had now at ASCO, there was a SEZ6 targeting one, a CD56, B7H3, DLL3, all of those are relevant in small cell, and all of those trials showed tremendous benefit in the patient populations they were given to, most of which were in small cell, or at least it was included. So now we have almost like when TKIs were first identified, you had this explosion of opportunity there. With antibody-drug conjugates, we're also seeing that too. And it's not only relevant for small cell, we're also using these in non-small cell, although they're not as universally effective there, I would say. So I think it's a brilliantly evolving field. And nowadays, many centers are going to have at least one trial with them. How
is this working in the brain? How are these?
So they work very well in the brain.
Did you say that already and I missed it?
No. You're spot on. So these therapies, as far as we can tell, do have CNS activity. They do have activity in the central nervous system. And for us, this is really until 2-3 years ago, we didn't have tarlatamab. We didn't have these. Once someone developed brain metastases, a lot of times we're looking at whole brain radiation. And these iterations are really, really changing how we look at small cell lung cancer, the prognosis. I've had patients now that are on these therapies that have been living for years. And that wasn't standard 2-3 years ago. The other critical element to know, as if an individual is listening who has a diagnosis of small cell lung cancer, once you've received one of these, by and large, you're excluded from the trials of the other ones because you've received that specific payload. The other thing to consider is if you've had a history of pneumonitis or inflammation of the lung, these may be particularly dangerous. So there are some considerations with the class of antibody-drug conjugate, but they're ushering in a whole new wave of treatment. And their benefit doesn't seem to be necessarily related to how much of that protein is on the cell surface.
Yeah, and I think when I personally think about small cell lung cancer, what we were missing for many, many years was this big old, word up here on the wall behind us. And I think we're seeing it now.
Yep.
With these new novel therapies. We talked about Lorlatinib. We talked about, ADCs and some of the other things going on. And I don't want to say it's exciting, because there's nothing exciting to a person who's been diagnosed with lung cancer, but we're making headway in the right direction, and that is something to be hopeful for.
Yeah, and now the difference from when I trained and I was seeing individuals with small cell lung cancer 5 years ago or so, to now I have a treatment plan. I have an arc of we're going to go to this, then we're going to go to this, then we have this, and then we see these trials. Whereas before, it was we had a few options of standard chemotherapy, but after they progressed in that first time, there wasn't a lot of hope. But now we have long-term hope, where this trial, people are on it for a year. This trial, people are on it on average for over a year. And it really does.
So on and so on, right?
You have a battle plan. You have a long-term battle plan.
I love that. So now I do want to circle back to you giving a high or medium or whatever level overview. We talked about tools in the toolbox. We talked about there's no one tool, right, to determine where someone might be either at diagnosis or even at progression. And that's ctDNA and MRD. How are these currently being used, and how do you foresee them being used in the future?
Yeah, I think the integration of ctDNA is getting integrated systemically now across institutions. We're still learning as a field how to best use these, to be frank.
Can you explain what they are?
Yeah. So what these are, they're blood tests. So we take some of the blood out, and what we're looking for in the blood is the DNA from the tumor that is shed into the bloodstream. Not only can we count the amount that there is, and that gives us a sense for, is treatment working over time or not? If that number is going up and we're counting more DNA, by and large, that's an accurate measure that the tumor is progressing. There's cancer growth. If that goes down, it's a fairly accurate depiction that the tumor is receding. This is really useful, I find, in situations where the scan is not clear. Individuals who have mesothelioma, it can be hard to interpret that kind of disease that's in the lining there. If you have lymph nodes that are reactive, is that a cold? I don't know. They just got a vaccine and now they have some hot lymph nodes on a PET scan. If the ctDNA is down, then I get some reassurance. So that's one element that can be used, counting it. The other element is qualifying it. Look at what it is. And this helps us identify mutations. Not all mutations are equally well identified on these tests. Notoriously, it can miss fusions. And I've had that example in my clinic as well, where individuals got the blood test, it didn't see something, they were treated accordingly, but they did have a targetable mutation, and you needed the tissue for that. So I think those are the two ways, and probably the biggest limitation that I run into in how it's used now, or at least in what the assay is. More and more, we're integrating this in trials and in our clinical practice to do additional monitoring as treatment plans go out. Insurance coverage is a challenge. It's not always covered. There are some indications that are covered. Resectable disease can sometimes be more easily covered. But by and large, if we're able to have a relationship with one of these companies that can provide this testing, I use it in probably one of two ways. One is if we have a disease that's really hard to track, I might use it with scans, and that will help me better interpret the scan. The other way is if we have a disease that's very comfortable to track with a PET scan, we know where the disease is and we can usually tell, I might get it in between scans. That way, if this disease goes up, I'll pull the scan closer in hopes of identifying something as early as I can. We don't yet know that that improves outcomes. And that's something we have to be really clear about when we talk. Sometimes these tests add a lot of anxiety because there is normal fluctuation like any test. So if it goes up by 5%, that can cause a lot of anxiety. So our hope is not to cause undue anxiety, but it's always a risk.
Yeah, and I think that, I think that makes perfect sense. But there's also people that it allows peace of mind for, right? And so it's one of the nuances of being a provider and a healthcare provider, particularly in cancer, is understanding and having those conversations, understanding your, the person living with lung cancer and kind of knowing which path to take, which is another challenge as a healthcare provider, right?
Well, and how many individuals who have a diagnosis of lung cancer are looking through your PET scan and wondering, what does this mean? How do I make heads or tails of this? Because the radiologist is going to mention a lot of things on that PET scan, even if there's no evidence of cancer. The blood test is a number.
Yeah.
So it can be really helpful if one gets that and it's 0, and then you see all this noise in the PET scan, don't know what that means, but at least this is 0. So that can cause a lot of reassurance.
This has been an amazing conversation, and no pressure, but I'm gonna close out with sort of a big picture question for you from your perspective, and that is, when you step back and you look at all of these studies put together, and even ones that maybe we haven't talked about, what are you most excited about for the future of how we're treating lung cancer?
Yeah, it's a great question. The thing I'm most excited about is how we're changing how we're using treatments we currently have to try to make people have the best outcomes they can, including with potentially adding surgery in areas we didn't before, and trying to improve the outcomes of individuals who got surgery. So these are the tools we're using now to push the envelope and really try to get more cures. I think those are the things that we need to push as hard as we can. The CAR T work, I think, falls in that category once we iron that out. And immunotherapy, the things that can lead to long-term durable responses, the envelope is being pushed.
I love that. Genevieve, yeah, before I close out, anybody, questions?
Is there any progress in terms of using AI to look at all past studies to find little gems that haven't been discovered yet in the data?
Yeah, so the question about using artificial intelligence, these machine learning tools, to gain insights from old studies, there absolutely are. We have this concept of a molecular, or a digital twin rather, where the algorithm can look at all these character attributes, so we can measure the amount of tumor, where the tumor is, what were the molecular details of that tumor, what treatment did they get and how did they do. Do that over hundreds of patients, and the machine will learn what are the elements that predict how one is going to do. And then it can spit back to us how is it weighting these elements. So it can figure out, what's more important for prognosis. And that gets back to the question of how do we do more for certain people and maybe less for others who may not need the same degree of disease intensification. When it comes to using machine learning and AI to better understand tumor biology, I think we're doing that too. It's not as far along to my knowledge.
I have a follow-up to that.
Yeah.
And I hope it comes out of my mouth the way my brain's trying to process it right now. So when we think about how we started this conversation with precision medicine, basically saying it's the individual's cancer, how can, and this is something I struggle with when I think about how AI is going to be used 30 years from now, you know? How can AI personalize it to the individual if we're using algorithms based on the masses, I guess?
Yeah, I think my best answer is the hope is you have enough information about all the individuals that were fed into it before that it can match those characteristics to you.
Yeah.
For example, if we had 30 individuals with, I don't know, actually that's a bad number, 100 individuals is an easier number, and we gave ALK inhibitors to everyone, this may identify it's the ALK fusion that helps you benefit from it, and then it will say, does this patient have an ALK fusion? That's where my hope is, that it will help improve all those things that we don't know, and how that might help us better direct treatment.
It's fascinating, and I, for one, am anxious and excited to see how AI is going to sort of roll out, and not just in healthcare, I mean, across the board. That's a whole different conversation, but I know it's becoming more and more relevant to conversations, to studies, to how we're moving forward.
Yeah, and can it speed things along? Our trial system is way too slow, in my opinion.
Yep.
Can we use this historical data as a standard, and it can do well enough to pair theoretical patient with the real patient, and then say it would have predicted you had 10 months, but actually you had 2 years.
Yeah.
That's a positive trial. We don't need a placebo arm or a standard of care arm. I'm hopeful we can get there. I think we're not terribly close, but I think we're moving in that direction.
Before I close out, are there any more questions online? Michelle, are you good? You have a couple? Okay.
Some ALK patients progress on Lorlatinib first line without targetable biomarkers. Suspicions is that it may be epigenetic bypass. Is there any work being done to identify why those people progress?
To identify why the epigenetic determinants of progression? Yeah, that's a good question. Geez. John, hey Mac, is that you? So that's a great question. And what this is getting at is there are elements that will regulate what genes are being turned on by a given cell. So if you have a pool of ALK positive cells, most of them are not going to progress, but a couple might. There's something about the regulation of genes that's probably doing that. And there is actually a lot of research going on into how are these regulators of the cell cycle, of if division is going to happen, if it's not going to happen. What are the things that make it start to divide again? These epigenetic regulators that modify genes being turned on and off. The challenge is those are really hard to target. So we can identify some of the regulators of going back into the cell cycle and growing versus just staying where you're at and not dividing, and you can stay there. But it is tough to weaponize those. But we have research programs even at the institution we're at Colorado. Many institutions are looking at this, but it's a tough question. And I think some of the way that at Anderson, where I was trained, and what we're doing now is maybe what we do is we identify those cells when they're at that state where those epigenetic regulators may be leading to something at the cell surface we can target. Maybe we can't target the regulators themselves, but maybe there is a vulnerability there. You can use antibody-drug conjugates, antibodies, CAR T cells. I think there are ways to weaponize that, and that's the next frontier.
I have 1% PD-L1, no actionable metastatic lung adenocarcinoma, and I'm being treated with the Poseidon, 2 chemo, 2 immuno. Any new stuff on the horizon?
So yeah, this is getting around this idea where for individuals who don't have the high PD-L1, how do you escalate your immune activation? So I think, what do we do to help with that? What's on the horizon? Part of that, even for individuals who may not be as responsive, or their tumors may not be as responsive to immunotherapy, I'll say low PD-L1 is not a rule. You don't have to do poorly on that. I know individuals who have low PD-L1 who have done very well. So I think, one, there's still hope there. But two, a lot of these other cell surface directed antibody-drug conjugates, the trials we have now, and we do have individuals getting great responses in those. So I think even for an individual who doesn't have these actionable genomic alterations we talk about a lot, the mutations, there is still a lot of research coming out that there are other ways to uniquely target those cancers, and a lot of it is at the cell surface these days.
Well, I think that's a great segue into me giving a plug for our clinical trial matching program here at GoTo. All of the conversations that we had today revolved around clinical trials, because without people such as those of you in the room who I know have participated, those of you who online, who either have in the past or may even in the future, thank you. Much gratitude, by the way, because without your participation, we wouldn't be where we are. But also clinical trials are hard to navigate, especially if you're not being seen by Dr. Concannon out in the greater Denver area in Colorado. So we have an amazing team of clinical trial navigators. They will help navigate you through not only better understanding of your biomarker testing and your biomarker results so that you can go back and have informed conversations with your healthcare providers, but if you are interested in clinical trials and you want support in finding a clinical trial that might be best suited to you based on your treatment history, your biomarker status, they can help you come up with a short list, if you will, to then go back and have conversations with your providers about. So that is our LungMATCH team. and they are a one-of-a-kind group of individuals. So please don't hesitate to reach out to us if clinical trials are something that you're interested in. Thank you.
Thank you.
This has been incredible.
No,
I'm so thrilled that you flew out here and you were able to sit here with us today and have this conversation. It's been really amazing.
No, it's absolutely my pleasure. Thanks
Yeah.
for having me. Nice meeting you all, and yeah, great
Yeah,
discussion. Happy
yeah.
to go through the best of ASCO.
That's right.
Exciting
That was
year.
amazing. Thank you. I'm going to go through a little bit of housekeeping before we give our big round of applause and thank yous to everybody in the room. So Gathering Hope is coming up next on August 11th. For those of you who aren't familiar with Gathering Hope, this is something you can absolutely do from your very own living room. It's the second Tuesday of the month is our general session at 11 a.m. Pacific. We have a second Gathering Hope every month that we just launched back in June, and that is specific to young lung cancer. So if you were diagnosed at the age of 50 or younger, please consider joining us and having conversations with people just like you who are walking the talk and have the same lived experiences. It's a community social where you're meant to interact with one another in ways that you are comfortable interacting. It's an online group. You can be on video, but you don't have to be. So if you've never joined, I highly, highly recommend you joining, and that's moderated by our very own Michelle Zay back there in the corner. Our next living room is August 18th, which is 2 days after my firstborn's birthday. And it's how surgical and radiation oncology work together. So we've got Dr. Megan Daly and Dr. Hari Kashava from the University of Irvine Cancer Center down in Southern California to come and talk to us a little bit about that. I want to give another big, huge thank you and round of applause to our speaker, Dr. Kyle Concannon. Thank you so much for coming out and speaking with us. A special thank you, as always, to Penn Media, Onyx and Ash, Michelle Zay, the events team for their support this third Tuesday of every month, coming out and help us pull all of this together. And then to my sister, who happens to be the vice chair of Go-To for Lung Cancer, for her very special personalized desserts that she homemade, home iced, home decorated here in the office today. So please make sure to either have one or bring one home with you. And most importantly, thank you to the people in our community, to all of you living with and caring for and loving someone who's either at risk or diagnosed with lung cancer. You are why we do this. You are why we bring this to you every day and why we do the plethora of other things that we try to do to support you. Thank you to all of you. And then I would be remiss in not thanking our sponsors, AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Ionis Foundation Medicine, Genentech, Johnson & Johnson, deep breath, Lilly, Merck, Natera, Novacure, Nuvation Bio, Regeneron, Revolution Medicines, Regal, and Summit Therapeutics. Without their support, we would not be able to bring this type of programming and our other support and education programs to you. So from the bottom of our hearts, thank you. And I want to give a very special happy almost birthday shout out to our friend Ina. She could not be here with us in person tonight, but her birthday is next Thursday. So I think she's watching from home. Happy almost birthday, Ina, and we will see you all next month. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only